Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning into the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology. I'm really pleased today. My guest is Ritesh Ramesh, the CEO of MDaudit. Ritesh, thanks for joining me on this episode of the Tate Chronicles.
Thanks, Jim. Great to be here with you.
Our topic today is revenue cycle management and AI. Some folks think this is somewhat of a dry topic, but one thing that we've learned, especially at the recent difficulties with the Change Healthcare hack, if something happens upstream, it can affect providers getting paid downstream. So the whole issue of making sure that the revenue cycle is as efficient and protected as possible is critical. I know that MDaudit operates, I guess, more or less in the mid-back end of the revenue cycle. So what are some of the strategies you employ to solve problems proactively before they actually even arise?
That's a great question, Jim. One of the things that, just to step back,
Sure.
in terms of really talking about the healthcare landscape this year, before I go into MDaudit and AI.
Sure.
Post-COVID, if you look at healthcare, demand's coming back strong. So healthcare does not have a demand problem. Folks are coming back in huge volumes, be it on the electives, be it on the office or hospital. So we see a huge surge in demand.
Mm-hmm.
Most of the hospitals and health systems are really trying to get back in green when it comes to their operating margins. So for the last 8-9 months, they have been proactively working on how should they really get to that number. And we see that operating margin picture also improving throughout the year, where most of the average margins are at least going towards 4%, which is great. But we see also a gap between the hospitals, which are the highest performers, and the ones which are the laggards when it comes to operating margins. And that is the headline for the industry: is how are they going to sustain these margins and also support the volumes coming in? And I personally feel that's where technology, automation, and AI comes in. Because if you really look at the operating margins and what's beneath it, there are 2 or 3 factors driving it. Number one is all the health systems and hospitals need to have a very strong revenue cycle management program so that they get paid on time. They get paid the right amounts for their services. And then the second driver of this operating margins are, of course, your labor and supply costs, which are starting to trend well than what it was last year, but it's still a battle for many of the organizations to optimize their labor so that they can really drive more and more productivity and efficiencies. So to me, what does AI mean in healthcare? There are 2 areas. Number one is, of course, on the demand side, people are doing a lot of clinical things with AI so that they can drive more patients to the front door and do things. But then when it comes to rev cycle management, it's all about supply and how you're going to use AI to ensure that you get paid on time for all the services you perform, and then drive your bottom line. And where MDaudit plays in is we are fully on the latter, which is the administrative RCM backend side, where we are working with our customers to have them really use their data and AI to sweep millions of data points, which is the denials and payments data, and really understand some of the root causes and hotspots they have in terms of difficulties getting paid with payers and for what reason, and then fix the broken processes so that they can make some progress. And that's where MDaudit plays a big role on that.
Yeah, let me ask you, and so are your customers primarily large health systems? Are those your customers?
That's right. We serve a lot of large health systems. We serve a lot of large physician networks and regional hospitals as well.
And one thing that you mentioned was identifying through all these data points where there is friction or things, identifying areas need to be fixed. What are some of the major things that you run across that need to be fixed?
Yeah, great question. Here are three examples. Number one is many of the systems have administrative and broken processes when they really submit a claim. Do they have all the information that the payer needs in a claim to get paid on time? Are they capturing all the charges for all the services they perform? Are the coders in the hospital system coding all the right codes? Because you know that the coding system is so complex with more than 10,000 codes for various different diagnoses. And that's where we put a spotlight on, look, who are your riskiest coders coding wrong claims? Who are your riskiest providers performing those services, where in some cases the providers are the ones coding, and who are they? What are some of the claims that is missing information? And all these type of analysis is powered by AI, where we bring in millions of data points and then have them perform that analysis in minutes and in some cases seconds, so that they can go and take some corrective action, be it educating a coder, educating a provider, fixing their EMR with some edits, so that those corrective actions are not only short-term, but they're also long-term and sustainable.
That's fascinating. So let me just paint a scenario and get your comments on it. So let's not maybe talk about a large hospital system. Let's just talk about an individual hospital. They're taking too long to get paid. They're obviously not coding everything. And so they call MDaudit. And y'all go in. Is that the first thing that you do, is just gather data to analyze their workflow and process?
That's right. So MDaudit is a platform which has capabilities both on the analytics side and AI side, which is our core engine, and I would call it as a core brain. And then we also have workflow capabilities which can automate a lot of corrective actions. So where the story starts is, yes, we collect all the data and centralize it in the platform. And then we run all of our AI and analytics on the platform, and we can easily find you the needles in the haystack. So if you're a health system who have multiple facilities, multiple providers, multiple payers, and you don't know where to start from, because many of our customers ask that question on day one is, hey, my processes are manual. Where can I start from? Like if I have limited resources, where is my biggest bang for the buck?
Mm-hmm.
And that's where we start, is to basically tell them that, hey, look, out of your 35 facilities, out of your 50 specialties, out of your, let's say, hundreds of payers, this is your biggest bang for the buck, when you can focus on a hotspot where you can allocate your resources and then make sure that those resources drive those outcomes. So that's where we solve that needle in the haystack problem when it comes to RCM and denials, which is very important, just because, as I said, resources are limited for many of the health systems, and they want to make sure that they allocate the right resources to the right problems, and we surface the right problems for them.
You know, you have so much experience looking at healthcare systems and the workflow and processes. I'm kind of curious, is the majority of hospital-based coding, is it overseen by humans? I mean, maybe, the coding may be generated by some automation or technology, but do human coders actually look at things before they go out, or is it all over the map?
It's a great question, Jim. It's starting to be all over the map. We have many vendors started to introduce this whole AI-assisted coding.
Mm-hmm.
But those tools are used for simple encounters.
Yes.
mostly on the outpatient side.
Mm-hmm.
And of course, what many of the health systems are trying to do is they want to make sure that they, again, allocate the human resources on the complex encounter side, mostly on the inpatient side, on complex claims. So we do have a hybrid approach where many customers use, I would say, humans to code, and then they use these AI assisted coding. Even with the AI assisted coding, there is a step where we are a big fan of. I keep calling this as humans in the loop.
Mm-hmm.
That humans in the loop is so important because if you think about it, you don't want to leave a machine to itself, because if it not only if it drives outcomes, it's great, but at the same time, if it drives errors for you, the problem is it amplifies the errors at scale. And we have seen that with many customers who went in, didn't have humans in the loop, and deployed these AI assisted coding tools, and then had disastrous results because once it made an error on a couple of
Mm-hmm.
physicians and couple of facilities, it took that error and scaled it to 2,000 physicians and 2,000 encounters
Mm-hmm.
facilities. So the amplification of bias and risk is a big, big issue. So that's why I really think that humans are very central. And if you're going to use AI, that's okay, but just make sure that you have humans in the loop who are always validating the results from the machine to make sure that you're driving the right
Yeah.
outcome.
You know, um, the regulations around coding and billing and new code sets for coding, those change over time. I guess the education and training of human coders is pretty critical.
Very critical. And I would argue that that is the last mile
Mm.
for any of your fixes or transformations to be sustainable, right? Because it's less about fixing a claim, it's more about fixing a behavior. So those are two different things. And that's one thing that we advocate with a lot of our customers is don't be very transactional when it comes to your corrective actions. Of course, fixing claims and releasing and getting paid on time is important, and that's what pays the systems, and that's what the CFOs are looking for. But then how do you make sure that this doesn't keep happening again and again and again, so that you're not chasing denials all the time without a strategic overview of, hey, what's my ecosystem look like? What payers do I have issues with? What issues do I have with each payer? These are fundamental strategic questions which you should be able to answer by deploying AI and analytics, which MDaudit does really well. And then we tell the customers that use those insights to either go and fix things in the short term, but also things like you mentioned, coder education, provider education, even working with your IT teams to fix your operational systems for certain edits and rules, which are very important. So that's very important, and to me, that is the last mile for a sustainable fix for
Sure.
your rev cycle issues.
Let me mention to our listeners, if you're just joining us, I'm Jim Tate, and on this episode of the Tate Chronicles, I'm speaking with Ritesh Ramesh, the CEO of MDaudit. And so, one thing we've kind of touched on, but I'd like to hear more details from your experience. So let's just say a facility submits a lot of claims. And some of those claims are obviously going to be denied, some percentage of them. And so, just based on your experience, what's a good way to handle? Should there be dedicated resources towards denial analysis, or is it just following the regular coders? Or what are some best practices for analysis of denials?
Yeah, I think what we have seen as an operating model across most of our customer base is you do have a transactional team within revenue cycle,
Mm-hmm.
which works your denials, which follows up with the payers, make sure he gets paid, then you post it. All that is great. But when it comes to analytics, many of the CFOs are starting to look at setting up a center of excellence, right?
Mm.
Uh,
Mhm.
and the center of excellence, again, it could be insourced, it could be outsourced, but the key thing for the center of excellence is to drive some strategic insights to the executives and the management teams. Because I often say that when you have a denial, it's not a rev cycle issue. Rev cycle is just a facilitator. It could be a coding issue, it could be a billing issue, it could be a clinical issue, and you just need rev cycle to bring together a bunch of stakeholders within the organization, sometimes to deploy this fix, including IT teams. So what we are seeing more and more is health systems are deploying these technologies and setting up a center of excellence so that you have a few folks who are great at analysis, who can mine the data and really kind of understand some of the strategic insights and trends, and then present it so that the rev cycle leaders and the CFOs can make some operational decisions, right? Like a simple example, hey, we have a big issue with payer A versus B, C, D. So what are the things we're going to appeal and get paid faster than what are the things which we're going to write off because it's not worth it? So that is a key strategic decision. And unless and until somebody has good data points, which can tell them what the issues are, where is it, they won't be able to make any of the changes. So center of excellence is where many of the systems are headed. And the analytics teams really work with the operational teams to manage denials, if that makes sense.
Yeah, it sure does. It makes me think of another question. So these claims are being submitted to various different third parties for payment. And so do the different third parties sometimes vary in the threshold of what they feel is an acceptable submission, or some stricter and deny more that others would maybe accept? I mean, if I know some critical information is missing, nobody's going to accept it. But is there some variation in their level of acceptance? Yeah. Wow.
That's a great question. So if you really look at it, one example I will give you is if you look at some of the denial trends which we published earlier this year from MDaudit, you see a very different behavior from Medicare versus commercial payers, right? If you look at Medicare, what we saw was the denial metrics, the number of claims they were denying, the average dollar which was paid for a claim, the wait days for your initial submission to get a response, all of that increased more than 60% on the inpatient side for the Medicare population, right? That's because people are going back, and Medicare has its own set of rules around reimbursement. And then if you look at the commercial payers, the behavior is very different, where the commercial payers are focusing on outpatient services. This is where your electives sit, this is where your most profitable services sit. And of course, the denial rates are not as large as Medicare, but still they're scrutinizing the highly profitable services for providers. So you're absolutely right. When it comes to the payer mix, there needs to be analysis because there's not one size fits all. And different types of payers, although you can argue some common guidelines and rules for different types of diagnosis and services,
Sure.
There are nuances. Some payers look for clinical and medical necessity. Hey, why did you perform the surgery? Could you have kind of performed something else for the patient which wouldn't have pushed this patient to a surgery? Why did you prescribe this drug, which is a branded drug versus a biosimilar? So that is one key thing that many of our customers, and of course the industry, is struggling with, is you have so many payers, and each payer their own nuance or rules, as they call it, and how should they really manage it? And that's where we also provide a solution which is very payer-centric, where we try to look at the denials at the rear view mirror with regards to a payer, and tell the customer that, look, with regards to this payer, these are the top 10, 15 services you have had issues with, and these are the reasons for the issues. And can you now take your findings from the rear view mirror and apply it forward so that you can proactively make sure that you're doing all the right things and collecting revenue on the time. So we take that approach of giving them tools where they can do a retrospective analysis and applying those insights prospectively or proactively to manage their denials.
That phrase, I've never heard it, but I like it, payer-centric. And so I imagine that is where AI would be helpful, gathering all that data from the different payers and coming up with game plans, that's relevant for each one.
Absolutely. And AI is huge when it comes to data analysis, and that's where AI shines, right? I'm a huge proponent, again, as I said, in terms of safe AI, as I call it.
Sure.
I think I'm still not comfortable having AI making decisions for humans. But what AI is good at is it can collect data, it can analyze, it can serve up results to the humans very quickly so that humans can focus their time and effort on looking at the data and making and driving those decisions. So this is where AI and humans can work collaboratively to drive some great outcomes. And that's where it shines. And as an example, as I said, the needle in the haystack problem is prevalent in healthcare, because if you look at a large health system, the health system pretty much has multiple entities. You have, let's say if you run into a health system, we have 15,000 providers. They are across 25 states. You have 70 facilities. By the time you kind of get into the different entities, you have this one-to-many relationship. And that's where everybody's struggling, because you go and ask them, hey, just tell me what are your top 5 issues. And everybody's like, well, yeah, I have my AR outstanding. I know how much payers owe to me, but I cannot go into the granular root cause analysis. And that's where AI can help you do that analysis faster, so humans can make good decisions.
We've talked about claim submission. For most folks, most patients, there's a portion of a healthcare bill that they need to pay, whether it's 10% or a copay or something else, really collections. And so can AI assist in the collections process? I mean, imagine 10 years ago, people would just get a letter or a phone call saying, you owe us this money, pay us. Based on, recorded feedback and data, there probably, I would imagine, be some way to fine-tune that in a way that works for not only the healthcare provider institution, but also for the patients.
Yeah.
Yeah.
No, absolutely. I think we have started to see some technologies emerge in that kind of horizon where when it comes to a simple example is AI is being more and more used in document generation, right?
Yeah.
And if you look at the administrative strain that it puts on a system with all type of documents which are being generated by humans, it could be a physician, or it could be somebody who in the RCM space who are basically drafting these appeals letters. Those areas are all up, because what AI is good at is taking structured data, making sense of it, and even generating responses. And that's something which we're seeing more and more. Systems are really looking at document generation as one big use case, be it clinical documentation, be it payer documentation, or even appeals letter. Absolutely.
Kind of hard to believe, but we're almost out of time. But before we say goodbye to our audience today, how can folks find out more about the services that MDaudit offers? I believe I've seen something that you have like some type of training thing coming up, or educational. Tell us a little bit about that.
Yeah. So for starters, we have a beautiful website. It's called www.mdaudit.com. And what's great about that website is you can learn a lot about our products in the website, but we have a lot of resources. These are webinars, educational webinars we run. These are white papers and reports that we put out, and there are case studies from our customers. So there are rich set of resources that you can actually download and educate yourself. And then what we do is for every educational webinar or event which we have, we publish it in our website. And even if you cannot attend our live webinar, you'll find recordings of all of our demos and webinars in our website. So I would recommend our website, which is www.mdaudit.com, as a central place where you could go and learn a little bit about us. And actually, you can even chat with folks from our organization or contact us through the website.
Well, great. Well, let me say to our audience, thanks for joining me on this episode of the Tate Chronicles. I offer a special salute to my guest today, Ritesh Ramesh. Ritesh, thanks for coming aboard today.
Thanks, Jim. It was a pleasure. Thanks for the opportunity, and hopefully there are some great takeaways.
I enjoyed it, and I learned quite a bit. You can find more information on this show's program page at healthcarenowradio.com. That's healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.